First of all, I'd like to thank Enzo for inviting me to this meeting. I got the email from him, and I was very excited, and I had to email him back and say, are you sure you have the right Dr. Lee? Because I do oculoplastics, and the whole program is ocular surface and cornea. And he said, no, 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 it's you. And so I'm very grateful. Thank you for having me at your meeting. This is a lovely, lovely city in your hometown. So thank you. I'm very grateful. These are my financial disclosures. So I'm talking to a room full of ocular surface experts, and you all know how to take care of the ocular surface. So my job today is to talk to you about how we can help with eyelids. What procedures can we do with the eyelids to help protect the ocular surface? Because we know that the eyelids are, the main function is to protect the globe and the ocular surface. We're like the gatekeepers. So it's really important to keep the eyelids in check so that they do provide enough support for the ocular surface. These are the common eyelid malpositions contributing to ocular surface disease. We most commonly see ectropion, lateral canthal tendon dehiscence, entropion, and lagophthalmos, and we'll talk about each of those and how we can address those. The normal eyelid position should be, the upper lid should be about 1 millimeter below the superior limbus, and the lower eyelid should be at the inferior limbus. So if you have variation from that, then you have to consider fixing those eyelids to protect the corneal surface. So for instance, this patient has minimal eyelid retraction, less than 2 millimeters. That can easily be fixed by addressing the capsulopalpebral fascia, so the lower eyelid retractors. And all you need to do is go transconjunctivally, make an incision underneath that lower tarsal plate, and then dissect down to the retractors. And you can verify that you have the retractors by grasping them and having the patient look down, and you'll feel the tug on them, and you release it. Then I put the patient on a frost suture for 1 week, and you can get about 1 to 2 millimeters of lift just from doing that procedure alone. So let's talk about ectropion. Ectropion is a big problem because we know it leads to tearing, foreign body sensation, exposure keratopathy because the eyelids are not blinking correctly, and conjunctival inflammation. Ectropion is usually due to involutional issues from disinsertion of the lower lid retractors, horizontal laxity of the lower lid, and stretching of that lateral canthal tendon. But when you evaluate your patients in clinic and they have lid laxity, it could be due to many different issues. You can have straightforward lower lid laxity and the eyelids well opposed to the globe still. You can have retractor disinsertion, which you see there on the upper right side, where the eyelid is fully flipped out, or you can have lateral canthal tendon disinsertion, and I'll go over each of these. What you want to do for any of them is horizontal lid tightening, either through a lateral tarsal strip, a lateral canthopexy, or a wedge resection. So I'm going to go over, if you do a horizontal lid tightening, just be aware of a patient that looks like this. This is called negative vector. So if the anterior surface of your cornea protrudes beyond the malar eminence, the cheek prominence, that's negative vector. And if you try to tighten this guy's eyelid, then it's like putting a belt over a fat belly. It just slips underneath the globe and it makes the eyelid retraction worse. And in that case, you need to build up the vertical aspect of the eyelid with a spacer. So I usually use hard palette, but you could use synthetics as well. But that's not the topic of the conversation. We're going to talk about first lateral tarsal strip, and I'll show you the steps briefly of lateral tarsal strip. So I do these under local anesthesia, just a lateral canthotomy with Stevens scissors. I dissect down to the orbital rim. I separate the anterior lamella from the posterior lamella, so I just take my Westcott scissors and dissect between skin and navicularis right on top of tarsal plate. I create a strip of posterior lamella and I remove that little piece of skin and navicularis. I use double arm 5-0 Merceline, and I take a double bite through the inferior and superior portions of that lateral tarsal strip. So I have a 2-point fixation like you see here. Then I throw that through the periosteum inside the lateral orbital rim. If you throw it through the top of the lateral orbital rim, then you're going to have distraction of the lid from the globe. So you actually need to go inside the orbital rim and march it up. And then I suture the skin closed. If you have full-on retractor disinsertion, which is ectropion, then you're going to want to do a retractor reinsertion. So transconjunctival incision at the lower border of that tarsal plate, extending medially to the punctum, laterally, dissect down to those retractors, which are going to be right on the other side of the conjunctiva. Again, you can verify by picking them up with forceps and having the patient look down, and you'll feel the tug. And then I throw a double arm 5-0 chromic gut suture through the disinserted retractors. Then we insert them to the tarsal plate, and then I throw the suture back through the inferior fornix. So it's reattaching the retractors to the fornix. And I usually throw about 3 of those sutures. So you can see before and after, and you want to overcorrect, obviously, and you also do an LTS with it to tighten the lid at the same time. So lateral canthal tendon dehiscence is important because you have to recognize this when there's a problem with the entire body of the lateral canthal tendon. What you'll see is that the patients have rounding of the lateral canthal angle, and every time they blink, the lateral canthal angle shifts medially. So you watch them blink. Usually patients have a pseudo upper lid retraction. So it's almost like a rubber band that's too loose. It just becomes more round, and you get an increased palpebral fissure height and pseudo lid retraction, and they have incomplete blink. So you take your thumb and simulate the effects of a lateral canthal tendon plication. Take your thumb, pull the lateral canthal angle laterally, and you can see there's much better closure. So I'm going to show you a video of this procedure. It's basically take your 15 blade, make a 1 centimeter incision just in the lateral canthal area, straight out horizontally, dissect down to that body of the lateral canthal tendon. And then I use a double arm 5-0 Merceline suture. I'll throw that suture through the body of the tendon. I'll actually throw not through that so it decreases cheese wiring. And then each arm goes through each cruce of the lateral canthal tendon. So I'll do a locking bite through the inferior cruce. I'll do a locking bite through the superior cruce. So I have almost like a strabismus surgery. And then I take that suture and I throw it through the periosteum inside the lateral orbital rim. Again, aiming to go inside first, then marching up to the anterior surface and exiting. So here you can see much better closure. You want to overcorrect because it always loosens up even a week later. Much better eyelid closure. Entropion, corneal and conj abrasions, because now you have the eyelashes hitting the ocular surface. You have foreign body sensation, sometimes infection, redness and tearing. This is also due to eyelid laxity, so horizontal laxity. You have to differentiate between things that look like entropion, which are common mistakes. So trichiasis, which are misdirected lashes. And if you look, the eyelid margin is in a completely normal position. So look at the eyelid margin. This is dystichiasis, where the lashes are growing out of the meibomian glands. And then epiblepharon is a very common misdiagnosis. So in children who have the fat, chubby cheeks and the skin orbicularis just override those lashes and push them up, that's epiblepharon, and those are treated differently. But if you truly see that there's rotation of the margin toward the ocular surface, then you're going to have to fix the horizontal laxity like I showed you before with the lateral tarsal strip, but you also have to rotate the eyelid. And most commonly, there are different ways: fornix sutures, retractor reinsertion, marginal rotation. Fornix sutures are probably the most common and the easiest thing to do. So what I do is I take a double arm 5-0 chromic gut suture, I backhand it down into the inferior fornix, and I march up underneath the skin. So what I'm doing essentially is taking my needle and catching the disinserted retractors and marching them up toward the inferior tarsal plate, and then I'm exiting through skin right beneath that tarsal border. So I'm essentially bringing the retractors up and reattaching them. And the reason I use gut is because it's the most inflammatory, because I want that inflammation to scar into place to put the retractors back. So I tie those. I usually put about 2 to 3, and you see the overcorrection here, but it heals quite nicely after you do the strip. Seventh nerve palsy, again, from people who have had either idiopathic bells, which we watch for 6 months to look for resolution, but if someone had a parotid tumor resection and you know that function's not coming back and they're left like that, they can have a lot of keratopathy. So with this, there are many options for seventh nerve palsy. I'd say that these are the most common. We already went over the lateral tarsal strip. The gold weight actually is a very effective, very simple procedure, easily reversible, very few complications. So again, I use this when the return of lid function is very unlikely and conservative management is not adequate. So you dissect a little pocket, just a tiny little incision in the lid crease, dissect down in between tarsus and orbicularis, and you put that gold weight right in that little pocket, and you suture it in with a 7-0 proline to the tissues, to the tarsal plate. You can also place it up higher on the levator, which will require about a 0.2 gram heavier weight if you want to disguise the bulk of the weight, because sometimes you could see that. So that's a gold weight procedure. Just real quick, some other things that you could do for exposure in kids or adults who can't undergo surgery. These are non-surgical management. You could see that there's quite a bit of exposure keratopathy there. This is use of botulinum toxins to drop that levator, decrease the actions of the levator aponeurosis to work as a tarsorrhaphy, and then dermal filler as a weight, as a lid weight. So I inject it on the upper, I inject it on the lower, and you can see much better closure. For my thyroid patients, because you don't want to close their lids, because we need the proptosis actually to forgive the nerve, right? We don't want to close the eyelids because it's going to cause more orbital compression. So these patients, a lot of times I'll use botulinum toxin up underneath a conjunctiva to drop the lid effectively, and I'll probably inject them every 3 to 4 months. Exposure keratopathy, if you have tumors in children, then you can do a tarsorrhaphy, which is surgical fusion of the upper and the lower eyelid margins. You could use a suture as a very temporary measure, or you could do permanent. You can do medial, you can do lateral, you can release it easily if you need to, and that's just dissecting anterior lamella from posterior lamella on both the upper and the lower lids, removing that mucocutaneous junction so that you have raw edges of the tarsal plate, which will adhere to each other, throwing some interrupted 5-vicral sutures through lamellar bites of the tarsal plate of the upper and the lower tarsal plates to fuse them together, and then you close the skin over it. So in summary, we've talked about different eyelid malpositions which contribute to ocular surface disease, including ectropion, entropion, lateral canthal tendon dehiscence, lag ophthalmos, and proptosis. We've talked about different procedures to fix them. I hope this was helpful to you because you guys are the masters of ocular surface, but just a little something to help. Thank you.